We're here to break down the new 2025 JSA Guideline for malignant hyperthermia. Our objective is a high-yield summary of the core updates and protocols you can apply in your practice immediately. Here's our agenda. We'll start with the key revisions in the new guideline, then move through pre-operative risk, intraoperative crisis management, post-operative monitoring, and we'll wrap up with definitive diagnosis and counseling.
So, let's dive right in. What's actually changed from the 2016 version that you need to know for your clinical practice?
Okay, there are 4 major updates to flag. First, and this is a big one, the initial dantrolene dose recommendation has been increased to get it in line with international standards. We're also seeing much more detailed guidance on genetic testing, specifically for RYR1 and CACNA1S variants. The guideline itself has been cleaned up. They've removed some of the redundant sections on symptomatic treatment. And of course, all the literature references have been updated. The focus here is clearly on boosting therapeutic efficacy and bringing modern diagnostics into the fold.
All right, let's turn to preoperative risk stratification. This is all about identifying and preparing the at-risk patient before they ever get to the operating room. A thorough history is absolutely paramount here. You're looking for any personal history of intraoperative hyperthermia, rigidity, or myoglobinuria. Family history is just as critical. You need to ask specifically about documented MH, known RYR1 variants, or even related conditions like heat stroke and exercise-induced rhabdomyolysis in relatives. You'll also want to screen for physical signs of associated myopathies, central core disease, things like that. Now, what about CK levels? Well, they don't have a high correlation, but idiopathic hypercalcemia should definitely raise your clinical suspicion. And this diligence matters because we know the reported genetic penetration rate for MH is right around 40.6%.
Okay, so if you have a susceptible patient, preparation has to be meticulous. There's no room for error. First, get all vaporizers off the anesthesia machine. You've got to replace the entire breathing circuit, the bag, the CO2 absorbent, the whole thing. Then, you're going to flush the machine with high-flow gas, at least 10 liters per minute, for anywhere from 60 to 100 minutes. And remember, that time is model-dependent, so check your machine specs. Of course, you'll use only non-triggering agents. TIVA is your preferred technique here. Make sure your dantrolene and sterile water are right there, ready to go for that initial dose. And this is critical. Absolutely no concurrent use of calcium channel blockers with dantrolene. We know that combination carries a serious risk of life-threatening hyperkalemia and cardiac arrest.
Now for the core of it all, intraoperative crisis management. When an MH crisis hits, it's a time-critical emergency. It demands an immediate, coordinated team response, and this algorithm is your playbook. This algorithm is the central framework for managing the crisis, so let's break down its components step by step. So, Phase 1, immediate response. The second you suspect MH, you move. First, kill all triggering agents. That means volatile anesthetics and suxamethinium are off. At the same time, declare an MH emergency and call for help. Tell the surgeon to finish up as fast as is safely possible. Then, hyperventilate the patient with 100% oxygen at high flow. We're talking at least 10 liters per minute to flush out any residual anesthetic.
Next up is the definitive pharmacologic intervention, dantrolene. Get that 20 milligram vial and reconstitute it quickly with 60 milliliters of sterile water. You'll need a large gauge IV to push it. Then you just keep administering it, titrating to effect, until you see those hypermetabolic symptoms start to resolve.
Let's talk dosing, because there's a key nuance here. The Japanese package insert says a minimum initial dose of 1.0 milligrams per kilogram. However, this guideline states a preferred initial dose of 2.0 milligrams per kilogram. And that brings it in line with the international consensus from groups like the EMHG, which recommend 2.0 to 2.5 milligrams per kilogram. What's really important to remember is that the JSA guideline doesn't set an upper limit. You give as much as you need until the symptoms resolve.
While you're pushing dantrolene, you have to be aggressive with systemic support. Get active cooling started immediately. IV chilled saline, surface cooling, and stop once you get the core temp below 38 Celsius. Treat the hyperkalemia with your standard protocol. Correct that severe metabolic acidosis with bicarb, and you absolutely need an arterial line for frequent ABGs and electrolyte checks. For arrhythmias, think amiodarone, but as we've said, stay far away from calcium channel blockers.
And I'm going to say this again because it is that important. This is a Class 3 harm recommendation. Do not give calcium channel blockers with dantrolene. The combination can precipitate life-threatening hyperkalemia and cardiac arrest. It's a critical contraindication.
So how do you know if you're winning? Through continuous clinical and laboratory monitoring. On the lab side, you're looking at serial ABGs, electrolytes, CK, myoglobin in both serum and urine, and a coagulation profile to watch for DIC. Clinically, you're looking for those key signs of improvement: ETCO2 coming down and normalizing, heart rate stabilizing, arrhythmias resolving, a return to normal thermia without active cooling, and of course, the resolution of that muscle rigidity.
Okay, so you've stabilized the patient. But we're not out of the woods yet. Let's move to post-operative management. The big concern here is recrudescence. And this algorithm gives us the framework for that vigilant post-operative care, helping us catch and manage any delayed or recurring symptoms.
The protocol here is clear. After an acute event, that patient goes directly to the ICU for at least 24 hours of observation, no exceptions. You'll continue monitoring core temp, ETCO2, and their cardiovascular status. The whole team needs to be on high alert for any sign of recrudescence, a rising ETCO2, return of muscle rigidity, or myoglobinuria. If you see any of those MH symptoms reappear, you restart dantrolene immediately. And don't forget to keep monitoring for downstream complications like DIC and renal failure.
All right, let's wrap up with the final piece of the puzzle: definitive diagnosis and counseling after the crisis is over.
When it comes to definitive diagnosis, you've really got two options. The gold standard is still the muscle biopsy with an in vitro contracture test, the CHCT or CICR. The problem? It's highly invasive, technically complex, and very few centers can actually do it. Your other option is genetic testing, looking for those RYR1 and CACNA1S variants. It's much less invasive, obviously, but here's the catch. It only picks up causative variants in about 50 to 70% of susceptible people. So, and this is a key takeaway, a negative genetic test does not rule out MH.
And that brings us to counseling, which is absolutely critical for long-term management. First, you have to explain that MH is an inherited pharmacogenetic disorder. This means blood relatives must be notified and considered susceptible until they're proven not to be. For the patient, they need to understand they must avoid all triggering anesthetics for life and always seek care at facilities that have dantrolene on hand. And finally, you should also discuss the potential risk from things outside the OR, like extreme exertional stress or heat stroke.
So this brings us to a final, very practical clinical problem. Given that a negative genetic test doesn't exclude malignant hyperthermia, what do you do with at-risk family members, especially when the proband has no identified mutation? Well, you're left with significant diagnostic uncertainty. The guideline mandates a conservative approach. You must treat all at-risk relatives as susceptible until their status can be definitively determined through more conclusive testing.